Next, we would like to invite Dr. Srujan. He's Senior Consultant Critical Care at Continental Hospital. He's going to deliver a talk on viscoelastic methods.
This one. Point of point. Point right. Good afternoon. Good afternoon. Once again, I thank ISCM Hyderabad for inviting me for this session. And my topic would be in continuation with the theme of trauma. Uh, Diagnostic test plays a major role in detecting early bleeding and clotting abnormalities. And viscoelastic testing plays an important diagnostic test in trauma resuscitation. So I'll be covering basically with the introduction, these headings with the types, the interpretation, the evidences in the trauma resuscitation, the strengths and limitations, and finally take home message. So now let's talk about what are viscoelastic testing assays. So these are the advanced diagnostic tests used to assess the functionality of the blood clotting process in real time, and it evaluates the dynamic and mechanical properties of clot formation, stabilization and breakdown. But why do we need these viscoelastic tests when we have the conventional coagulation tests? This gives us a real-time holistic in view of an ex vivo clotting, and it assesses the physical clot properties during the transmission of blood from a liquid to a gel state. That's the reason it's been given the viscoelastic property of the blood, which helps us in the main principle involved in this testing. Now coming to the different types of viscoelastic testing, it is done using two types, which is the thromboelastography and a rotational thromboelastometry, TEG and ROTEM. And the TEG works by the principle by measuring the mechanical properties of a blood sample as it clots and then breaks down. Whereas the ROTEM uses a rotational technique to measure the weight of clot formation and breakdown. So it is performed with different reagents to assess different aspects of coagulation. As you can see, the principal difference between the TEG and the ROTEM is that the oscillating is the cup in TEG, whereas it is stationary in the ROTEM, and the stationary pin is stationary and oscillating in the ROTEM. And almost the graphs are also, except the nomenclature, it looks almost similar. So these are the different types, subtypes of ROTEM, and the subtypes of ROTEM gives the most important thing is INTEM. The advantage of ROTEM over the TEG is that it measures the intrinsic pathway using a contact activator, whereas XTEM tests the extrinsic pathway, coagulation pathway by tissue factor. The FIPTEM isolates the fibrinogen's role in clot formation by inhibiting the platelet function, and APTEM measures the clot stability with platelet inhibition to assess fibrinolysis and clot stability. This is the basic interpretation of the commonly used, which is TEG. Most of the Indian ICUs use TEG, so I am just avoiding ROTEM, but basically the principle remains the same except the nomenclature. So to start with, uh, it starts with the R time, which is the time to initial clot formation and the time to the first base reaction, and the controlling pathways is the coagulation cascade. So the interpretation is if the R time, the normal R time is around 5 to 10 minutes, and if the R time is prolonged, If the R time is more, then it is a hypocoagulable state. And if it is R time is less, then it is a hypercoagulable state. And usually we'll administer fresh frozen plasma as a therapeutic intervention. After R time comes the K time. It is a time to reach a pre-specific clot strength, and the normal K time is 1 to 3 minutes. And the controlling pathways are the fibrinogen cleavage and fibrin polymerization. Here also, if K time is increased, it is hypocoagulable, and if it is decreased, it is hypercoagulable. Then comes the alpha angle, which is the rate of clot formation, and the angle between the baseline and the is intersects the fibrinogen cleavage and fibrin polymerization. Here also, the alpha angle is the normal angle is 50 to 60 degrees, and if the alpha angle is increased or decreased, then you need to administer cryoprecipitate or fibrinogen concentrate. Then comes the maximum amplitude, which is the greatest clot strength achieved, and the clotting pathways involved are the fibrinogen activity and the platelet quality. Here also, if the angle is decreased, it is hypocoagulable, and if it is increased, it is hypercoagulable, and you need to administer platelets. The next comes the lysis at the rate of clot breakdown at 30 minutes, and then it will be at 60 minutes, where there is a decrease in the curve at 30 minutes. This is the place where fibrinolysis starts, and that is the if it is decreased, we need to start with tranexamic acid. This is the difference between the two TEG and ROTEM waveforms. The only difference is the nomenclature. Otherwise, the waveform almost remains the same. And the common ROTEM pathways are assimilated to our day-to-day activities so that we can easily remember and the treatment to be followed. Now coming to what are the indications of this viscoelastic assessment. Why do we need this? So usually in trauma patients, usually a trauma patient arrives in an ER in a active bleeding state, in a shock condition, penetrating injuries, with a acidotic, with intracranial bleed, with a solid injury, and these patients need an initial TEG to rule out any coagulation abnormalities. Once the patient is bleeding, if he is taken into operating room, there can still be an actively bleeding patient with coagulopathy and clinical decompensation and requiring more active blood transfusions. There also there is the need of your viscoelastic testings. And after the surgery is done, when he comes to the ICU, you need to monitor his coagulation and blood transfusions. And that stage also, you need to have a TEG. So what I was talking about mostly is the trauma-induced coagulopathy. This plays a major role, and that's where your TEG plays a major importance in than other uh, coagulation tests. In the early TIC, trauma-induced coagulopathy, there will be bleeding and tissue damage, and this will be a hypocoagulable state. And later in the TIC, there will be thrombosis and organ failure, which leads to a hypercoagulable state. The time from the hypocoagulable to hypercoagulable state is vital, and that's where you need the requirement of assessing your clotting abnormalities. So TEG plays a major role in this, and we don't know how much time it will take for somebody to go from TIC, early TIC to late TIC. We'll talk about evidences, how many studies were done for this requirement of TEG in your ICUs. The first and the foremost study which was done was the goal-directed hemostatic resuscitation of the trauma-induced coagulopathy, a randomized control trial. They have taken 111 patients and they have compared with the normal coagulation assays, and they assessed the primary outcome was overall death, and in the early death less than 6 hours. As it's a trauma and they could detect early, definitely the TEG patients had an improvement. And the need of transfusions, it was statistically not significant, but the need of FFP and cryoprecipitate was definitely changed. So the conclusion of this study is improve the mortality, improve the survival, utilizes less platelet and platelet transfusion during the early phase of resuscitation. Then there was a prospective observational multi-center study where they have created a data-driven development of used both ROTEM and TEG algorithms for the management of trauma injury, and they have set some thresholds for all the fibrinogen platelets plasma of ROTEM, TEG, and the common. This one, and these studies also definitely not improve the survival, but it helped us in improving the morbidity of the patients. The only study which is the important study is the ITACTIC study. This is the only multi-center randomized control trial in trauma patients to date conducted following validation of studies of TEG and ROTEM. Here 203 patients were allocated to conventional coagulation tests and 200 patients were allocated to viscoelastic testing. The primary outcome they looked for was the patients alive and free of massive transfusion, and the secondary outcome they looked out was the 28-day mortality. But they didn't find any difference in mortality or massive transfusion at 24 hours, and no difference, secondary outcome also, there was no difference in the overall mortality at 28 days. But there was a subgroup where they looked for severe traumatic brain injuries, which showed the TEG-based algorithms received lower FFP and platelet transfusion than the control group. Then a systematic review study was done to guide the hemostatic resuscitation in trauma patients. And here also, although some studies demonstrated VHA guided strategy benefit in reducing the need for blood transfusion and mortalities, the evidence is still not robust. The quality of evidence was robust by limited number of such studies, and there was greater heterogeneity and severe risk of bias, and further studies are definitely recommended. This is the latest European guidelines, 6th edition, which they have graded the goal directed strategy guided by standard laboratory coagulation values or VM as grade 1B. This is one more study showing the resuscitation in severely injured patients. Here they made a propensity score. So the propensity score matched comparison was done between VHA and CCT. Among 7,250 patients, they could only make 215 patients and divided both of them. And the result was a VHA based strategy was an increase in the number of patients alive and free of multiple transfusions at 24 hours, together with an important reduction of blood product use and associated costs. However, that did not translate into an important improvement in the mortality. Now, the role of TEG and ROTEM in damage control resuscitation, as the most common is that you direct the early transfusion of FFP even when your clinical gestalt has not activated your MTP, multiple transfusion protocol. The reaction time and clotting time detect significant levels of direct oral anticoagulants, and the slow clot kinetics suggests the need for transfusion of fibrinogen via fibrinogen concentrates or cryoprecipitate. And the lowered clot strength can be corrected with both platelets and fibrinogen. Now, coming to the strengths of TEG or ROTEM, the rapid assessment, it helps in the rapid assessment of coagulation status and its derivatives. It is used to guide administration of specific blood components. It helps in analyzes all the three phases of coagulation: initiation, amplification, propagation, reflecting the interactions of coagulation and fibrinolytic systems. TEG-based transfusion algorithms shown to reduce transfusion of blood components and reduce the rate of surgical re-exploration. It is the best indicator for hypercoagulable state in postoperative patients. And TEG, choline, and ROTEM is useful in detection of inadequate hepatic reversal or hepatic rebound. The limitations: it is poor at detecting conditions affecting the platelet adhesions like von Willebrands. The preoperative baseline of TEG are poor predictors of postoperative bleeding. Tracings are insensitive to aspirin and clopidogrel. Methodology is yet to be standardized in terms of sample collection and processing. Although tracings appear similar, they are not interchangeable, and agreement between TEG and ROTEM is remote. The last study, which is the latest study, which was published in October 15, 2024. So it is conducted by Neha and Thomas Parker. Should viscoelastic tests be a standard point of care in all ICUs? So definitely in making diagnosis in bleeding patients, definitely a faster diagnosis and avoid unnecessary transfusions. And in non-bleeding patients, more accurately excluding the DIC. And it also helps in differentiating all the three coagulation states and avoid unnecessarily transfusions. For prognostications, screening for DOCs and antiplatelets can influence the timing of surgery, invasive procedures, and administration of reversal agents and acute hemorrhagic management. We need to balance between the finances, between the expenditure and the possible savings. Definitely the machine consumable maintenance is high. The staff training program is robust. But the advantage we will be saving is reduction in the blood transfusions, reduction in the ICU stays and length of stay, reduction in the OTs, re-explorations. So, and the service requirements is like a hospital needs to have a 24/7 service, quality assurance you are testing, and accurate interpretation. And the limitations would be it is insensitive to protein C and von Willebrands, insensitive to mild to moderate fibrinolysis, and that's so on. The last take home message I would like to tell is viscoelastic tests identify fibrinolysis, a finding associated with slightly increased mortality, yet one that no conventional coagulation test can reliably detect. Using these parameters, guided resuscitation begins within minutes of patient survival, and a growing body of evidence suggests that this approach may improve survival while reducing the volume of blood products transfused. Thank you.
Thank you, Dr. Srujan, for that informative talk on viscoelastic testing. And I think we'll be moving very soon for the personalized blood transfusion strategies in ICU.